Simon Bell, but Caroline Goldsmith is attending on his behalf. So thank you, Caroline. Apologies from Paula Evans. Apologies from Sharon Stoll, but Fiona Phillips is stepping in for us on her behalf. So hopefully she can feed back for us. If I ask any of you if you have got any declarations of members' interest as we go through, anything other than we are already aware of, could you please flag that up to me and we'll deal with it as we go along, if that's okay with everyone. Right, if I ask everyone next to look at the minutes of the next meeting, which I'm certain you've all read, and I'm looking to you for agreement that these are a true and accurate record. Yep, nods of approval. Thank you, everyone. Matters arising, we only had one, but Sean, that's in hand. It's to be arranged, so, and that was around the primary care dashboard. Is that a yes? Yeah.
Yes. Sorry, yes.
It's okay. It's good. I get that response from my husband as well, but that's fine. He's known me a long time. Right, we go straight over to you, Caroline, if that's okay. So this is the financial report for month 9.
Okay, thank you. Straight in there. So just a few bits to sort of highlight from the report. I think the report's got most of it in there already, so I'll just bring out the main points. We're now working to a full 12 months rather than 6 months. So this has got the full year forecast in there. There's a few areas of spend that are outside of what we call allocation, so they're outside of envelope. We're not funded them up front. We incur them and then we get allocation in retrospectively for them. So there's a few bits in there for the Winter Access Fund, the additional roles reimbursement scheme, SMS text messages that are to do with the COVID vaccination programme, and asylum seekers. So if we look at the delegated position, we're currently 441k underspent after you take out the outside of envelope spend. So that 103k in the outside of envelope relates to Winter Access Fund and was based upon the plans that we'd received from the hubs at that point in time. And then the other bits of variants are all explained. It's kind of a PMS premiums that budget's in here, but the spend's in other primary care. So unless there's loads of questions, I'm not going to go into loads of detail over that bit. It's worth noting that there's now income protection on minor surgery, some elements of the IIF and QOF. So those bits have been forecast back up to budget. And then when we look at the core primary care, section 3.2, we're looking at an overspend there of 22k once we take out the outside of envelope spend. There's a couple of items in there that's outside of envelope. That's the SMS text messages for COVID vaccinations and Afghan refugees. The prescribing position is something worth of note because we're looking like we're overspent on there at the moment. Actually, October's prescribing figures were quite a bit lower than we would normally expect based on historical patterns. So we have accrued extra in there because we're expecting that to be caught up at some point. We have done a bit of looking around the patch, and it's general across the whole patch. Prescribing was down in October, but it's very unusual. So we are expecting it to come back up, but we will be monitoring it in the next couple of months just to see how it fluctuates. And there is a medicines optimization company that are looking at generating some savings on a risk share basis, Optum. So hopefully that can help us keep control on prescribing. So unless there's any particular questions, I wasn't going to say anything else on that section. In terms of forecast, oh, sorry.
Oh, no, it's okay. I was just going to say thank you, Caroline, and I wondered if anybody did have any questions. And I know, yeah, David.
Yeah, it may not be the right point, Caroline, but the I forgot the name of the company that's taken on the optimization of prescriptions. Is it
Optum, I think they're called.
Optum, something like that, isn't it? Yeah.
Yeah.
Is it too early to say whether that's having any success?
My understanding is from the meds management team that we should start to see some savings in November's prescribing. So we haven't got that data yet. We'll get it anytime soon when we start looking at month 10. I think they thought that it was possibly less than what they'd originally expected, but until we start getting the data through, I wouldn't like to say either way.
Yeah, okay. Well, could we ask that we have regular reporting on that? Because I think it is a risk that we need to keep an eye on, really.
Yeah.
The prescribing position is quite well, it's not precarious, but we're well over, aren't we?
Yeah, it's really difficult. It's very volatile, isn't it? But it's ups and downs. And like I say, at the moment, we have actually got an additional accrual in for October because we just cannot understand why it would be as low as it was. It was much lower than normal months, and actually October is generally a really high month. But time will tell with it until we see. But yeah, we can definitely keep some reporting on how the optimization is going.
Because we were seeing this morning that there's a kind of a lapsed effect, that people haven't been going to the GP or to A&E because they've been trying to keep the pressure off people working with COVID and so on. So there's a longer term kind of bulge coming through, and it may well be that reduction is something to do with a brief spell and actually come back and bite us.
That is what we wondered, really, which is why we put it back up, because it was just totally unexpected. So we have got some coverage in there should it go back up again, but it's very volatile and it's very difficult to predict exactly how it's going to go.
Yeah. Okay. Thanks.
Okay.
Thank you, David.
So I was just going to say that on the forecast for the full year there, we are forecasting full utilisation of the Winter Access Fund and our additional roles funding. So the additional roles, we've got about 56% of our funding in our allocation, and the rest of it we have to draw down from NHS England if we utilise it. We're currently forecasting to need that additional funding from NHS England, because we're looking at the plans that we've got. The PCNs are trying to spend everything that they can. I think there might be some slippage, but at the point we had to do the report, we weren't quite in a position to know exactly. So we're forecasting everything, full utilisation of both of those. But overall, we're expecting an underspend of about 594k after the envelope spend.
Thank you, Caroline. Tim.
Thanks, Julie. I'm feeling very invigorated and full of life today. You'll all be very pleased to know. I just thought we ought to take a moment just to consider, we tend to look at budgets in isolation. Just wanted to make the point that looking at a prescribing budget in isolation does have its potential downfalls, in that there are unseen costs of this work. And they're not big, but they are there. So, for example, I can think of at least 3 patients who booked an appointment with me because they've been approached by Optum to change their medication. Now, I appreciate in the spiel there will be no impact on general practice. This is all being done outside of general practice. But these are patients I've known for many years. And when you make a change to medication, someone who's been on medication for many years, they want to check with their regular GP that this is all okay and this is approved. So I don't have a way, I can't stop those people that, that I would encourage them to discuss their issues with me. But those 3 patients who booked with me to discuss those changes, and I've reassured them that they're absolutely fine, the logic behind it. That's 3 other patients with a medical need that couldn't get to see me because I don't get any extra appointments. So although we might be saving a bit of money on the drugs, and I don't know how you measure that. I just think we need to look at primary care in the whole, and that getting down on a budget, one particular budget stream, doesn't necessarily mean we're delivering a good quality service. So yes, it's right, to shop wisely and to buy your drugs at cheapest price and make sure there's no excess prescribing. But I just wanted to sort of throw that in there as a counterweight to this very sort of financial, which has got to be financial process of looking at budgets, and maybe say there's a softer side to healthcare delivery that, because it can't be measured, gets overlooked. So I'm not saying there's an answer. I don't mind. I've known these patients for 20 years. It's my job to help them through this and talk these changes through with them. But it does have an impact elsewhere on the system. And if you have a lot of things like that, then those little things become big things over a patch the size of the Vale of York. So I just like to throw that in there.
That's wonderful, and it's a really valuable comment, and I think it goes with the grain of our finance and performance meeting this morning. Very much we were discussing it's people, it's the impact on people, it's patients, and I guess for us it's for us to be mindful of the knock-on effect of any decisions that we make. So it's really valuable. Thank you, Tim. Phil.
I'll try and link everything that has just been said by Tim with what we shared at Finance and Performance Committee. A couple of areas. The financial numbers are simply reflecting the change in practice that's being partly driven by COVID and the necessary reaction to that. So I guess that one of the biggest drivers for the 98 grand underspend in minor surgery is that activity locally is just crowded out by the amount of time that clinicians are having to spend combating COVID with their patients. The second thing, Caroline, is that picking up this theme of taking a broader view, but it's taking a longer view as well. So, the performance of the in-year budget, when you know the environment that activity, that funded activity is actually trying to deal with, being very predominantly about either break even or underspend is quite remarkable. But how do you feel about the recurrent position? We had some discussion of that this morning, that there's a significant difference between what the in-year financial performance looks like and actually what the performance of the recurrent position is, that in the end, the ICS will inherit not only from the Vale of York CCG, but all its other constituent bodies. What's the recurrent position like, Caroline?
If I'm honest, I don't know. It's very difficult to tell in primary care because there's so much sort of non-recurrent funding in there at the moment, that it's sort of skewing everything. So I can go back and look at it if you want, but there's, off the top of my head, I wouldn't like to answer. I can't say, because so much has been changing each year. There's additional funding going on in all the time. There's the new DES contract streams and stuff, and a lot of that we don't actually know yet whether that is going to be recurrent. We haven't got the DES contract for next year to know what is going forward and what will be continuing. So in terms of the spend and what is and isn't recurrent, it's very difficult to actually pull out at the moment.
Okay, all right. Yeah, it's just a marked contrast with the world that I grew up in as a finance professional, where at the heart of all of our financial tools was a 5-year medium-term resourcing strategy. So we looked over 5 years. So predominantly it was about what was recurrent. But you're right. I said this morning, there's loads of penny pockets of 1-year funding at the moment, isn't there?
It's just littered with it all the way through, all of those things. Stuff's changed. The income protection, that all has an impact. It's very difficult to strip all that out to actually see what the recurrent position is.
Yeah. Okay, thanks.
Thank you, Phil. And you're right, they're the things that are giving us added challenge, aren't they? All those little pockets here and there that are not recurrent. So it's difficult. Thank you, Caroline. Very much appreciated, giving us a lot to think about. I think that's it for questions, unless you've got anything else, anyone? Okay, thank you, Caroline. If we move on to Fiona and Gary now, please, and that's for the Primary Care Networks update.
Thanks, Julie. You've just got me today rather than the pair of us. I'm going to have a go at sharing my screen. I always struggle a bit on Zoom, so we'll see how it goes. I hope, I can't see very much now, but I hope what you can see is Vale of York CCG PCN update.
He's thinking about it, Gary. Give it a moment.
Okay.
Yeah, it's hamster needs feeding, the same as mine did this morning, I think.
Mm-hmm.
It's slow.
You're teasing us.
Not intentionally, I can assure you.
We've got a black screen with your name on, Gary.
I hope that's not as good as it gets. I've got a note here saying your screen sharing is paused.
Oh dear.
Ah.
Right. Is anybody else able to help us here?
Gary, take yours down and start, and I'll see if I can share.
Yeah, so mine should be down now.
That was telepathy, because it was Steph I was looking at. She always knows it.
There you are.
Brilliant. Excellent.
Needed a woman's touch, Gary.
No,
my life.
That's the other one I did earlier today. That's the COVID hub update. It's the PCN update, Steph.
Right. Start talking.
Okay.
I'm not saying that the hub update wasn't interesting. It was fascinating, but it's not the topic for here.
But it shows you what a team we are. They're supporting each other, and I just went when it comes. I hate Zoom because it doesn't behave for me. It's very naughty. So, how are we doing?
Hey, fantastic!
Lovely, thank you.
And of course, because I'm not in control of the slides, I get to do the Chris Whitty thing of next slide, please. Next slide, please, Steph. So I'm gonna cover two things. One, very briefly, which is the clinical director in community nursing, and then spend more time on the Winter Access Fund. As of this month, we now have two clinical directors, Dan Kimbling and Emma Lange, who've taken up a joint clinical leadership post with the Trust nursing team, community nursing team. They're only a couple of weeks in. They only had their first meeting with hospital management, I think yesterday. And they represent and work across the whole of the Vale York footprint for the community nursing team. So it is a really collaborative piece of work across the PCNs. And the vision, quite simply, of both the nursing team and of the PCNs is to improve communication between the primary and community care teams, work on pathway inefficiencies, and put that local patient care on the agenda of a new Vale York primary care network forum where all the CDs are present and discussing just the community aspect. So it feels really positive. It's taken a long time to get going, but it feels the right thing to have done now that they've done it. And the major part is going to be on the Winter Access Fund. So a very brief kind of introduction to this. I'm going to do a what the Winter Access Fund is, how as a CCG we approached it with our PCNs, and then a bit of an update on what we see being delivered. So as a brief introduction, in October last year, there was a £250 million national plan for improving access for patients and supporting general practice. We got some data down from Nhs Ei, which more than anything highlighted the gaps in patient access as a result of COVID. Funds were designated to regions or ICSs, with CCGs invited to develop and submit plans, really about increasing capacity and addressing areas of variation. The Vale York plan was £1.1 million, and that received approval in November 21. I've been waiting to do this so long. Next slide, please. We took a very consultative approach to how we wanted to manage this. We were aware of some of the soft and hard politics that sat behind it. And we carried out a number of engagement events with general practice throughout October and November. And we arrived at two fairly simple conclusions, really. The first was that the best way to support any individual practice was to support all practices. And then the best way to support all practices was to build on the PCN development that we've seen across the Vale of York, with hubs of place, really, that had kind of a demographic and a system and a philosophical alignment. And I'll show you how we kind of created those hubs and what's unique about each of them. And it was really with the aim of facilitating local collaboration, practices to collaborate locally, to provide mutual aid with the additional resource while they're recovering to the best of their ability, appointment levels to pre-pandemic levels, increasing face-to-face consultations and building resilience across primary care for what we knew was going to be a tough winter. The one thing that GPs told us right from the get-go was that finding additional workforce would be an issue. Most of it would come from existing practices, our staff within existing practices, and that they already felt burnt out. And I think after that, we then had Omicron and the booster campaign, and I think that put even more challenges on the primary care workforce. Next, please, Steph. The 4 localities, we know them actually, don't we? So, you know, we've got the North locality, a large number of relatively small practices covering a vast geographic area, limited access to urgent and emergency care centres, large numbers of over 65s, mostly not in care home settings, so quite a unique challenge for them. In the city, we've got 4 PCNs, including 2 large single practice PCNs, where all of the geography overlaps and is all has proximity to ED. And in the east, Tim's PCN, 3 practices serving 43,000 patients in a mixed market town and semi-rural geography, all using EMIS. And Pocklington, unusually to the rest of the Vale of York, received their community services from Humber FT. So arguably a bit clumsy to manage in any other context and allowing East to make their own decisions. And South, mix of large towns, semi-rural practices, some practices closer to Leeds than York, 80,000 patients in total, UTC on the doorstep, and a bit of a desire before, during and after the Winter Access Fund period of November, December through to March, to look at working more collaboratively across urgent care with the UTC. So 4 really distinctive areas. Next, please, Steph. We had some common aims working on these localities, with practices within those localities, making the most of existing resources and capacity. Some of the practices and PCNs are using clinic or e-consult to support remote triage. The aim was always to improve access to same and next day or urgent care across a wider workforce than just GPs, improve access to face-to-face appointments where it was clinically appropriate, and that became more difficult again with the Omicron wave, and also free up capacity to maintain routine care. Localities told us that on the whole they would do this by creating additional sessions from their existing workforce, locum GPs, and a really wide variety of clinical professionals to provide that support. And if they were unable to provide those clinical sessions from their existing workforce, then they would look at remote consultation platforms such as Push Doctor to fill that gap. We also agreed that all practices would update and share their GP bypass numbers with Nhs so that paramedics had access to shared clinical decision making within GP hours. This is something that already existed, but Nhs were telling us that their access was variable. The aim was to be consistent across the Vale of York by the end of December, and in actual fact, that finalised, fully validated list only went out today. So it gives you some idea the amount of work that goes behind some what appear to be fairly small objectives. The community pharmacy consultation scheme was integral within the Winter Access Fund aims. Vale of York achieved 100% sign up across all practices. And then the booster campaign come along and kind of blew that off course a little bit with community pharmacy capacity. And we're very much between Fiona and I looking to pick that back up with our localities throughout February and March. Next, please, Steph. We also want to do a review of ED attendance, and we have George Scott has created a joint CCG practice BI team, and they've been mapping attendance at ED by proximity and also by neighbourhood deprivation. This really builds on the work presented by Stacey Marriott to the UECN, I think probably October, maybe November time. And the conclusion is that deprivation is at least as important as proximity, and in some cases more important than proximity. And it does, in the city, it impacts practices that generally have higher ED attendance rates than other practices. So Haxby, Priory and York Medical Group in particular sit right in the heart of these 10 LSOAs that we've identified as having higher than average deprivation across the city. And the same work's been done across the Vale of York PCN, so in the north, south and Tadcaster and rural. And George is working his way around PCN meetings throughout February to share these results and see what we do with them, really. Next, please, Steph. Comms was something that we agreed very early on that we wanted practices to communicate with their own practice populations, explain how the winter arrangements were going to work on this kind of locality hub basis, and supporting patients to access the right care in the right place at the right time. But actually, by the time we got into the Winter Access Fund proper, we had Omicron come along and the whole system was under intense pressure. And it just felt a bit inappropriate. So you've now got this enhanced level of access to your general practice, when actually that had been blown off course, and access to all of the health and care was also being blown off course. And so what we did, we between North Yorkshire and Vale of York comms teams, we built packs to provide supporting materials to practices that supported self-care, that supported appropriate access to general practice, particularly that wider multidisciplinary team, and also protecting frontline staff, especially receptionists, who through the latter part of the summer and autumn had just faced an absolute torrent of abuse from frustrated and angry patients. So we wanted to do something to protect that front line. I'm going to mention oxygen supplies in GP practices. This wasn't in our original plan. But the pressure on the ambulance service meant that patients attending general practice, respiratory patients, who then needed an ambulance calling, were waiting anything up to 4 hours in practice for the ambulance to arrive, and practices were running out of oxygen looking after that patient. So we put some of the winter access funding towards making sure that every practice has a lifeline kit and upgraded oxygen bottles to keep patients and staff safe. It really did cause some staff some real consternation, the worry about running out of oxygen with a patient present. Next, please, Steph. I want to talk a little bit about the approach that we took across Vale of York. I don't really know whether it was that different to what anywhere else did, but we had a very definite way that we wanted to do this. And by working with localities, we delegated 90% of that total reimbursable budget down to the localities to take the responsibility and decision making for how they were going to put that extra capacity in when we knew it was difficult to find. And then we held 10% back as a contingency in case we needed to do at-scale solutions. And the oxygen supply in GP is an example of that. Between Fiona and I, we've worked hard, I would say. I think we've worked hard together across the 4 localities to develop and support the delivery of these plans with the whole primary care commissioning team and the finance team in support. And knowing that Caroline's on the call and at the risk of embarrassing her, she's been fantastic. So I will say that, as is Sean and Steph, actually. Let's embarrass everybody. I think pretty much as we expected, because we created it that way. Each of the localities have taken their own approach. They're all quite similar, but they're all quite distinctly different. There is a locality flavour to what each area has done. And my personal view is that that paid off, because we didn't plan expecting Omicron, but when it came, the closeness of local GPs having access to that resource meant that they could put things in place almost at a micro scale, at a practice level, much more quickly than we could have done with any degree of scale, and they had the freedom to do that. So the upshot of that was that all 4 localities had additionality in place come the 1st of December, and I think that was some going by the PCNs, to be honest. And we had a fairly simple measure which allowed the localities to have some flexibility in what they delivered, rather than just additional appointments. The standard rate for a remote consultation of any of the platforms is about £23 an appointment. What we said was, if you can deliver additional appointments at under £23, every time you do that, you get a little bit of flex to do something that builds resilience. It might be clinical administration, it might be non-clinical admin, it might be building different bits of team, but it supports the resilience, which gives you the foundation to deliver those additional appointments with. And as a proxy measure, we started recording and tracking GP Opal status as Omicron hit in mid-December, as a proxy measure, just to see whether across the Vale of York we had a sense that our general practice as a whole community was resilient. Nearly there, next please. Vale of York had a fairly ambitious plan, I think, of 46,000 additional appointments through November through to March. We lost November because of the kind of a planning process that we had to go through in the approval process. But like I say, we were up and running in all localities by the 1st of December. And as we sit here now with the returns that we've had so far and the feedback that we've had so far, the estimate is that we will achieve about 75% of the plan that we expected. The aim, I think, of all localities is still to achieve 100%, but that is utterly determined by the access to additional workforce and the resilience of practices to be able to put that workforce in place and deliver those appointments. We think we fell slightly short in December, but it's too early to tell because we haven't got all of the invoices and returns in to be able to count it back. And I do think we see a step change in February and March when Central, for example, will bring on 8,000 appointments over 8 weeks using Push Doctor across those 4 PCNs. So that's where I think we see that step, but it's a little early to call it yet. Next, please, Steph. In terms of the measures, really we're looking at using the GP appointment data to measure total appointments and total face-to-face appointments across December through to March. And anticipating that, we've already got a bit of a tracker of what was delivered in terms of total appointments, which I'm showing here in October to March in each of the 2 previous years and the current year. It is frustrating for me today. I was hoping that the GP Access Data Portal would have been updated, so I could have shown what December actual total appointments were today. But the best laid plans of mice and men, hey. And I think when we do come to do the measure towards the end of this financial year, we're going to need to context it in terms of what happened regionally and nationally with appointments and the impact that Omicron had on that. Couple more and we're done, Steph. So in terms of the other measure that we had, this was a soft measure, a bit of an ambition really, that by adding that resource of the Winter Access Fund, that we wanted to be successful in creating an environment where practices were resilient and didn't need to report escalated OPAL levels. It's a funny one, this, but it was an ambition that sat underneath this. And we know that in late August, early September, we had some really high levels of OPAL 3 reporting across general practice. We're under a huge amount of pressure, as was the rest of health. And that was kind of our benchmark. So we started tracking this, and it looks a bit like Tetris. But I think, and I've tested this with GPs yesterday at our primary care ops group, and it feels warm rather than hot or cold. And does that feel like general practice to you at the moment? And the overwhelming picture is, yes, that might be a multitude of practices, but it also feels like what our practice feels like. Practices who've reported escalated levels of OPAL have almost without exception done so on the basis of staff absence, which is that wicked mixture of having COVID, self-isolating because they've got family members with COVID, and general sickness. And also, I would say, if you look to the right-hand side of that chart, as Omicron rates have eased, we've also seen less OPAL 2 and 3 being reported. And it's a good tracker to keep running this, because I think as restrictions ease back, I think practice staff will become increasingly exposed to COVID, because people won't be mask wearing. Very often they'll be positive and not know it. So I think it's an ongoing challenge. Winter feels far from over. And the last slide, I think, please, Steph. So I think just as a roundup and a summary, the approach of working with GPs across their PCNs, across localities, has helped us maximise the resource available through the Winter Access Fund. I think Omicron and the booster campaign blew everything and everyone off course, but that's been the nature of the past 22 months, hasn't it? I think PCNs, if they deliver 75% of this plan, I think they will have done amazingly well. And I think the additional capacity to see patients and stay safe and resilient throughout winter has been fantastic, really. It's been a great thing to be able to put into place. The measures are in place to measure the effectiveness and the deliverability of the Winter Access Fund through those main criteria. And I can't end this without saying that GP practices have thoroughly appreciated the resource and support that they've had through the Winter Access Fund. Thank you, Steph. And I'll kind of lay that open to questions and comments.
So I'll come in there, I think. Well, firstly, thank you to the CCG primary care team. We talk about this as if it had weeks and weeks and weeks of planning, but we were really talking about something that happened in November. And as we started to talk about winter access funding, and we've already had a little bit of a conversation about non-recurrent monies that land on you, planning and utilising £1 million that you weren't expecting takes some planning. And I know the team, as sort of highlighted by Gary, did a lot of weekend late night working with practices and PCNs to deliver that. So on a procedural note, that's our PCN and our Winter Access Fund update. So thank you for that. The ongoing issue about one-off monies that we don't plan for continues to be an issue. So I do think that we need to understand, as we work in a new environment, how we will address that. It goes without saying that our practices and with the support of their PCNs have really pulled out all the stops. And to be honest, we, from our NHS sort of regional and national colleagues, we get a lot of military language slipping into what they want of us, and they talk about going again. We know you're exhausted, but you need to go again. So as Gary highlighted, and I'll come on when I do the vaccination program update, when we ask these additional measures of our staff, they are all the same staff that we ask the new requirement of. So I think that we've had some really good outputs. And when we'll share these slides again, you get a moment to look at that activity data. We hear a lot of rhetoric about pre-pandemic activity, when in actual fact our practices have been delivering more than pre-pandemic for over a year, and not by small amounts of activity, but by significant amounts of activity. So I do think it's truly commendable what we have managed to achieve across the Vale of York out of hospital community. So I'll just pause there, but I do think once Tim's had his comments, I would just like to come back and see whether we can have a conversation with Dave around what we think as a community, what NHS England might be thinking about in terms of future contracting, future funding that gives practices a bit more level of stability to plan and continue to recruit, so that we're not always doing this extra push every winter. Thank you.
Thank you, Steph. Over to you, Tim, please.
Thank you for that, Gary. Thank you very much. I think two things, probably a statement and then possibly a question. I think Steph summed it up really well there. It's not money we necessarily need, it's staff. It's the same staff doing the same job, or we have a stranger on the end of a video screen who's never met the patient before, who is not going to meet the patient again, is unable to do blood tests, is unable to follow up or do repeats, and then passes that work back to the GP practice that they're supposed to be helping. And if that's the model we want, that's the model we're encouraging. So unless somebody somewhere has a good look at primary care and starts to provide quality clinicians to work in primary care through the recruitment and retention of GPs, that's the model we're going to slip to. And I can only presume that the population are happy with that because they're not kicking off. And I suppose the question is, maybe to the lay people here, because it's hard for me to be objective, how do you feel about a GP service that's moving to being essentially on Zoom with no ability to examine you and no ability to follow you up? And are you happy that that is the way you want the service to go? Maybe that's an unfair question, but it's what worries me and it's what keeps me awake at night, is how do we take the good things, which are the continuity and locality of general practice, which time and time again in research, and I believe there was an article published in the BMJ last week showing a link between continuity and quality of care for dementia patients. How do we square that circle with that is what people want and what gives good outcomes, but that isn't what we're commissioning and funding as an NHS at the moment? Don't necessarily expect an answer, but I am genuinely curious as to, is that what the general public really want, or is it what we're stuck with because of the situation we've got in with poor planning? I'll leave it there.
We've got a lot of pensive faces there. Thank you, Tim. A valuable question. Gary, thank you very much for the presentation. It was excellent, and if we can share that, please, that would be wonderful. It'd give us that extra time. Answers on a postcard to that one. Are we throwing ourselves to the wolves? I don't think we are. I think I know what the answer is going to be. David, please.
Yeah, I mean, just a quick response to Tim. No, of course we don't want that, and neither do members of the public really. But I think what we should be doing is making sure that you don't have to contact a GP every time that you need the service of a clinician. The pathways where people can speak to physiotherapists directly, for example, in my local area, are saving people immense amount of time. You can actually ring a physio, get a diagnosis and get some treatment without even involving the GP. And that's just a very simple example, but there are lots of other ways that we can improve primary care but still maintain the most important thing, which is that face-to-face contact and an examination. But, you know, maybe, as you say, it's inexorable and that's the way we will end up. But I think it's our job to try and protect GP time for those times when it's really needed, and to widen the scope of other clinicians to do what they do best.
Thank you, David. Steph, over to you.
So I think there's likely to be an emerging role for the primary care collaborative, and the point that Tim makes about the workforce is, well, the issue is well understood. And we are fortunate in that in the Vale of York, it is a place where people want to come and work. So I do think that we need to join all those dots together around who has the lead around workforce and recruitment, and then its consequential knock-on effect around making sure that there is a physical environment in which to home them as well, so that a multidisciplinary team can work together. So I would always be an advocate of the benefits of non-face-to-face activity where it's clinically appropriate. But nobody should ever sort of imagine that will overtake face-to-face activity. So we do need to join these things up, and in an environment where we don't know what the traditional commissioning landscape will look like through the ICS, we probably need to have a very firm understanding and identity about what we want to do in the Vale, what we want to do in the city of York. How do we support our East Riding population, just to make sure that some of these service transformation and developments don't lose momentum.
Thank you, Steph. Any more questions or comments? Yeah, quite an interesting discussion there. And I think it's left us, as usual, probably with more questions, which is good, because it means that we go away and we think about it. Anybody wants to contact me later about any of their thoughts, I'd be really interested. And thank you all for your honesty. It's emotive. It's people we're talking about here. So thank you all. If we're ready now to move on, Steph, it's over to you for the COVID update, please.
Yeah, before I commence, Andrew wants to come in.
Got his hand up. Yeah, sorry, Andrew.
That's okay. So I was keeping quiet until we'd heard, you know, if we're going to have a discussion with Dave maybe about the NHS England side, because I think Steph's right that really chucking a load of money over a few months every so often is not great, especially when it comes with caveats and the kind of rhetoric around the face-to-face stuff. And I think that was a big problem with the Winter Access Fund, as well as the kind of stipulations that were required. And Gary and the team did a fantastic job of doing their best with what they were given, but it's what they were given that was the problem. And I also know that local NHS England colleagues are extremely supportive, so it's not a criticism of anybody, but longer term, that is true, isn't it? You know, I think we could recruit, particularly in the Vale of York, if we could offer posts that were kind of innovative and interesting to new GPs, that wasn't all just about firefighting, but this money, this Winter Access Fund money, you know, it really was. It was just urgently trying to find capacity, scrabbling around, dealing with the wrong question. You know, access is the wrong question, capacity is the right problem to try to be solving. And I think that was the frustration that was felt by primary care, who, as you say, have worked with the CCG to make the best of this. So I think it is worth considering, you know, is this just likely to be a recurring thing? Every so often we get to a crisis and then there's a bunch of money thrown at it that we have to scrabble around and use in some kind of desperate bid to make the best of something? Or do we feel positive that in the new NHS there will be a sustained commitment to just better funding of the infrastructure that can avoid these last minute dashes, I guess. But it's, again, that's not a criticism of anyone on this call, by the way. It's just I thought we were going to lead into that discussion.
Thank you, Andrew. Any comments for Andrew?
Well, I can sort of come back in. I guess in terms of confidence of the funding moving forward, I'm not cited enough on it at all, so I'm not even going to sort of try and fudge a response. I think we're kind of used to one-off non-recurrent funding. I know I think Sean and I have this sort of issue with a lot of the digital funding programs. And actually, the more you spend the non-recurrent funding when it comes through, which is sort of in essence the thing we feel we should do as commissioners, the bigger the problem you have in a year or 2 years' time when those initiatives come to an end. So I don't think that's anything new. Completely agree with the WAF funding. I think it instantly just showed what the main concern is, and that's workforce. Again, I don't think we have the immediate answers. It's top of the primary care collaborative's priorities. It's obviously a high priority in the NHS England planning, but I don't think necessarily the solutions are there. I know in the planning guidance there's a lot of reference to sort of a change in culture to I suppose more around retention of staff than necessarily recruitment. So no, I have to admit I don't really have the answers at this stage to that. Whether or not locally the ICS has a bit more influence to invest from outside of primary care and be more transformational, we'll see. But no, I'm sorry. In terms of NHS England nationally, I'm not any better cited, I think, than anyone else on this call, as is the norm.
Thank you. The honesty is wonderful, and I think for me, very much, I don't like little pockets of money that are thrown at things. I like, things to be planned, because it enables you to put everything else that you need in place to make sure that things happen in a timely way. Monies are spent, I think, more effectively and more efficiently. But we can only be the voice that actually keeps on saying that to the ICS, to the ICB, and just continue to keep vocalising on behalf of the people that we care for. So thank you. Steph, over to you now, please.
Okay, I'm going to just give you an update on the vaccination programme, and while I'm talking, maybe Fiona might come in at the end of that to talk about case rates and case numbers in our local area. So it feels like a long time ago, doesn't it, pre-Christmas? But that's when we were asked to roll out the booster campaign. So just for anybody who isn't aware, who's listening to this, first dose, second dose, then a booster, or first dose, second dose, third dose if you're immune suppressed or in a vulnerable group, and then your booster is your fourth dose, as we understand it now. So we've had really good success. If we think about those people that we count, we talk about being fully vaccinated with a booster, we are as Vale of York in excess of 80%. And when you think about how the booster program has worked, about protecting the vulnerable in that sort of order, when you think about the age profiles, 90 plus, 80s, 70s, and so on and so forth, those ages above 50, 2 vaccinations and their booster, we're in the high 90s for some of those eligible cohorts. So booster campaign is still rolling out. One day I think we had 8,000 patients come for their vaccination, which was really our top vaccination number in the whole of the programme. Just a little about our providers. Obviously in the city centre, we've got the Askham Bar site, but actually we've got providers all around the Vale of York, supported by a whole range of partners. The bedrock is our primary care services, but we've got our pharmacies supporting that service as well. So the other thing to sort of really make the point about is that we've got some people who have yet to make that choice to come forward for their first vaccinations, and we really want to encourage people to come and have that evergreen offer. Pre-Christmas we saw new people coming and taking their first vaccine, and then they'll become eligible as time progresses for their second. So it's 3 months between 1 and 2, unless you've actually got a COVID infection. So I think we progress through the numbers. It's our best protection, and it's the way in which any new variant, we hope, will be minimalised as well. So we know that there's still some geographical areas where take-up is low. So we continue to work with partners to make sure that we're flexing our offer to ensure that people know that they can take up their vaccines. The tail off, we had a huge spike in activity over the December period, but it's now quite slow. Our vaccination providers are currently focusing on younger age groups, particularly younger age groups, anywhere between that sort of 5 to 16, and it's in 2 chunks. Anybody who's in a vulnerable category. So, and we continue to roll out and support partners with the school program as well. So we still run the vaccine service. It is not compulsory. But it remains a choice, but we would encourage anybody who hasn't had their vaccines. So I will pause there and invite Fiona to talk about rates, and then, if I may, I'll come back and talk about mandatory vaccinations for healthcare workers.
Thanks, Steph. Yes, I'm sure probably people have been keeping an eye on what's going on in the press and looking at numbers and things. But just to confirm, our current rate of cases, this is a rate per 100,000 population, currently stands at 880 in York. That has been coming down, and currently is the lowest rate in the region and lower than the England rate. Obviously, with Omicron coming to our area and now being the dominant variant in our area, we saw a massive spike in cases sort of through December and into early January. So our peak was on the 4th of January, and at that point our case rate was 1,858, and that's the highest it's been at any point through the pandemic. So what's driving that mostly now is cases in younger children, so particularly the 5 to 9 age band, and just generally children in primary school settings, really. So if you look at that 5 to 9 age group, the rate per 100,000 is 2,770. So that's where we're seeing most cases. And then a little bit on the back of that, we saw an increase in the kind of 30 to 45 age group, who potentially will be a lot of the parents of those children in primary schools as well. So that kind of household transmission driving rates as well. The positive part of it is that the over 60 rate has continued to come down. So we monitor that, as those are likely to be the more vulnerable groups. We know that children, unless they're sort of children with complex medical needs, children are not likely to become significantly unwell or be admitted to hospital with COVID. So case rates extremely high, and what we've also seen is hospital admissions. In previous waves of the pandemic, you get cases and then hospital admissions rise, and then after that you would see deaths. So we saw a rise in hospital admissions as rates started to go up. What we haven't seen is that particularly lead through to any peaks in deaths, and it's a slightly confusing picture as well in terms of what's happening in hospital, because there's obviously people in hospital who test positive for COVID, but they're in hospital for something else. So it's quite difficult to get a very clear picture about who's actually in hospital because they've got they're being treated for COVID. So at the moment, there's about 100 patients in York Hospital who've tested positive for COVID. And as a rough estimate, it's likely that about a third of them are in there being treated for COVID. The thing that we kind of monitor in terms of hospital admissions as well is those who are in ITU, which obviously gives us an indication of those who are severely unwell, and that figure hasn't really gone up. So we tend to kind of have anywhere between about 1 or 4 patients with COVID in ITU. So we've not seen peaks in those patients that we saw in other parts of the pandemic. So I think, you know, on the back of what Steph was just talking about, clearly the vaccination programme has made that step change really in what we're seeing in terms of the pandemic at the moment. So hence kind of all efforts to getting as many people through to be fully vaccinated as possible.
Thank you, Fiona. Can I just quickly ask those that are in hospital, have they been vaccinated or not? Are we taking those statistics?
Yeah, so it's a question that we regularly ask, and I'm never quite clear on whether it's actually recorded and collated anywhere. So when I ask the question, I tend to get quite a sort of anecdotal view of what the situation is at that current time, rather than collated stats as such. And what I've been told most recently is of all the cases in hospital, and remember that some of them won't be in there because they're getting treated for COVID, but of all the cases, it's about a 50-50 split of those who are vaccinated and those who are unvaccinated. And then what I'm told is that the patients who are treated in ITU are largely unvaccinated.
Thank you, Fiona. Any more questions before I pass back to Steph? David?
Yeah, thanks, Fiona. I mean, you probably, you know, this is probably just something you can't answer, but I'm always interested to know what's the thinking within public health circles about what's going to happen next. Is there going to be, do you think, other variants, or are we beginning to see, you know, the end of this as a pandemic? I know it will always be with us, but is there going to be another spike, do people think? And is there going to be, you know, are there going to be other variations?
Yeah, so yes, crystal ball time, isn't it? And try and work out what might happen. With any virus, you know, the more you have of it circulating, you know, the more opportunity there is for variants to develop. So I think there's, you know, a strong feeling that we will see other variants, whether they're variants that are of concern. So, you know, the main concern being if you had a variant that was more serious, or a variant that had more significant vaccine escape, that would be the things that would concern. So probably will be other variants, but what we've seen in each wave through sort of Alpha, Beta, Delta, now to Omicron, each variant that we've gone through so far has been a bit milder, and then obviously having the vaccine program on the back of that as well has helped. As to whether, I think there's a kind of a public health view, and then there's a view in terms of what the government decide to do in terms of some of the sort of approaches to the virus. So for example, at the moment, the legal duty to self-isolate if you have COVID, at the moment, that ends at the end of March. So if that change goes ahead and you're no longer asking people to isolate, on the one hand, you solve some of these issues that we've got at the moment with staff not being able to work, children missing lots of education. So, on one hand, you solve some of those issues, and you're essentially saying that COVID becomes something like flu that, we have to live with. But clearly, in the background, the UK Health Security Agency will continue monitoring. And, as I say, if you potentially get to a point where you have a variant that's of significant concern, some of those measures might have to be stood up again. So I think we're just going to be in quite an uncertain period for quite a significant time to come, maybe.
Thank you.
Thank you, Fiona. I just wondered how we were doing lateral flow tests, whether we're able to get the kits across York, whether there was a time when they weren't as readily available.
So what basically happened over Christmas is, you had a lot of people who wanted to do lateral flow tests because they wanted to visit family at Christmas and wanted to do that safely. And then changes to the guidance, which was about if you tested positive for COVID and you did testing at a certain point in your isolation, you could end your isolation early. And then the other one, if you'd been a contact of someone who had COVID, you didn't have to isolate if you did daily LFTs. So that kind of drove the demand up. So we, just in terms of what we see reported, and we know not everyone reports their lateral flow test, but from what we saw reported, it went from about 18,000 tests a week to almost 50,000 tests a week. So it was a massive increase, and that put pressure onto the national kind of delivery systems. And also it was Christmas as well, and the government used the Royal Mail to send out home testing kits, so they were under enormous pressure at their busiest time of the year as well. So it was kind of perfect storm of lots of things happened at once. So we always had kits at our test sites. We've got 3 test sites that we operate as a council. So we've always been able to have a supply of kits there, and we saw an increased demand in people coming to those sites. And then what we were able to do as well is we had a sort of period where we were trying to support, we provided some kits to primary care, we had to support some schools, people like the police and others. So we kind of kept things moving. What we've been told now is that there's much more increased capacity through the online ordering portal, and people shouldn't have issues getting those. Pharmacies as well, they're another source. The issue with pharmacies is that they get a daily delivery because there's only so much they can keep in the pharmacy. So it is a route for people to go to, but it's kind of when they're gone on a daily basis. And then we still have our test sites, and we're able to have kits there for people to come and collect from. So I've not heard that people are struggling at the moment, so it should all be fine for people to either order them online or find somewhere to pick them up. But obviously, if people out there are reporting that they're struggling, we'd be interested to know that, and we can try to find solutions.
Thank you, Fiona. That's really reassuring. Steph, can I go back over to you just to...
Yeah, certainly. And yes, I'd like to thank CYC colleagues who did help us out with those additional test kits when we had a bit of gap in provision, and thank Fiona for that. I always enjoy listening to yours and Sharon's summary. I think they're really helpful. Thank you. I just wanted to conclude by just highlighting to committee members about the work that's going on with partners and within the CCG, just to assess and action the requirement that all health staff who are engaged in CQC regulated activity to be vaccinated, and that's a mandatory vaccination as a condition of employment, and that comes into effect from the 1st of April. So if the guidance doesn't change, to be fully vaccinated by the 1st of April, that's a first and second dose. So unless you are exempt, you'll be required to have had your first vaccination by the 3rd of February. So work's ongoing, and it's your employer who is doing that work. So the CCG are doing it for their own staff. If we have any CQC regulated activity, which we don't, and acute trusts and GPs as employers as well are just going through that work. So I just wanted to mention that because that's part of the guidance, and it follows on from mandatory vaccination to work in care and social services. So we may see an upswing in activity at the vaccination sites as staff choose to take up their vaccines if they are eligible and not exempt before that 3rd of February deadline. Thank you.
Thank you, Steve. Can I quickly ask you, we're still supporting people with a conversation? I know we were doing that. If people were concerned, would we be doing that? Lovely.
Yeah, absolutely.
Thank you. That's invaluable. Sean, it's over to you, please, for the risk register.
Okay, so I'll just give you a quick run through this month's update. There are no new or additional risks that have been put onto the register this month, so we're still working with the 3 usual ones, which is the serious mental illness health checks, the access to general practice, and the sort of general practice staff workforce wellbeing. So I'll just start off with the headlines for the Smi Health Check. So the national target for this is that 60% of people with serious mental illness should receive their sort of 6 core elements of their health check within a 12-month period. And I think it's fair to say that practice have made some real progress with this year. You may remember that we had the learning difficulties health checks on the risk register last year, and we've been able to remove that because practice has made really good progress with that particular piece of work. And I think this is certainly heading in the same direction. So against that 60% target, the Vale of York Q3 performance is 41.5%. So still rising on Q2, which I think is in itself a real achievement, considering the pressure that practices have been under during that sort of Q2, Q3 period with all the COVID sort of activity and requirements as well. So out of our total SMI register of 2,547 people, 1,056 of those have had all 6 elements of their health check, which is really good progress. Just in terms of the approach, there's been some interesting developments. Primary Medical have done a lot of work around digital first access to these health checks as well, which has really helped in terms of access. And all of the City of York PCNs have made improvements through some coordinated admin work to identify patients and really promote these health checks and invite them in. And that work will continue through 22 and 23. And then I think another interesting development is this joint work that's going on with City of York Council Sport and Leisure to expand the delivery of those sport and activity experiences to people with SMI and help them to kind of participate in those activities. So I think that's more of an engaging piece, isn't it? Where obviously partners are trying to engage with this cohort of people, which will help them with their general health, but also gives an opportunity to engage with them to try and do some of these health checks to understand how they can be supported going forward. So I think that's moving in a very positive direction. So we'll continue to update on that one. The next risk is the access to general practice and the reputational damage. Now, we talked a lot about this, haven't we, already in this meeting with the winter access funding, our various efforts to improve access to general practice. And I think, as Gary mentioned, you can see from the charts in the report that actually practices are delivering more appointments than they were pre-pandemic, significantly more. If you look back at November, which is our latest data, so November 2020, there were about 139,000 appointments in general practice. And this November, we're up to 170,000, which is a significant increase. And it's probably worth also mentioning that the numbers that you see here on this NHS digital report, I don't think tell the full picture, because there are practices now who are using some of the digital consultations with their own GPs to see patients, and systems like Clinic, which they're using to triage patients and contact patients, which aren't counted in this data that comes through nationally. So I think the reality is that the number of appointments is actually far greater than we're probably seeing reported nationally, all credit to our practices. So I think Gary's already run through the sort of the WAF schemes, but in addition to what you see there, I think from December onwards, we'll see a lot more appointments coming through that reporting, which have been delivered through the Winter Access Fund, taking on board everybody's comments about, you know, whether it's a sustainable thing, and this one-off funding, you know, isn't a sustainable solution to this, and workforce is the answer rather than the funding. But in terms of the raw numbers, I think we can all kind of agree that in terms of patient access, there have been significantly more appointments that patients can get into, which I hope will be reflected, you know, in the patient surveys around access and ease of access into general practice. So although we are, you know, we continue to be aware of the public kind of issues around this, and we are continuing to work with the comms team around the public messaging around access to general practice as far as we can. And then the third and final risk is the general practice well-being, which I think we're still concerned about this. We acknowledge that all practice staff have been under huge pressure, and we can see that through the OPAL reporting, which helps us as commissioners get a much better feel for what's actually happening out there in general practice. So it is helpful to monitor that, and although it's sometimes difficult for us to intervene and give any real practical help in terms of those workforce issues, we're hoping that by at least kind of surfacing these in almost a real-time basis, I suppose, with the OPAL reporting, we can really start to try and work at scale on some of those kind of mutual support type schemes that we're trying to deliver through WAF, and trying to keep those going, I suppose, on a more sustainable basis, workforce and funding permitting. And then just to note at the end of that, as part of our work through the Humber Coast and Vale Primary Care Ops Group, which is the primary care leads for all of the current CCGs, we work really closely with LMC colleagues through that group around trying to fund and develop the LMC's engagement with practices in terms of wellbeing, support and mentorship for all types of staff across our practices in the region. So I'll finish there. Thank you.
Thank you, Sean. Any questions, comments? No, delivered so perfectly. You haven't even got a single question. Just an observation from me. It's fabulous for us to actually see that, as far as I'm aware, when we listen to the press, they're not slating and berating quite as badly as they were, and I think that's in part due to some of the information that we have been able to share across the patch. So I think we just keep sharing that story and working closely together and looking after each other. Right, okay, moving on. It's back to you again, Gary, please. Is it? No, it's Caroline. Sorry.
Is it me?
Yeah.
Okay. So the next paper is about investment in primary care reports. So the GP contract was obviously updated a year ago and now spans a few years. And as part of that contract, the CCGs are required to report on how we've used our primary care allocations. The contracts have obviously changed quite significantly in the last few years. So I think the objective of it is to be able to evidence that we're still putting the same amount of money, if not more, into primary care, and that funding hasn't been lost along the contractual changes. So there's 2 reports attached as annexes to the cover sheet. The report for 1920 and the 2021 report. So overall, the sort of top half of the report is main contract spend, including GMS and PMS contracts, QOF, any enhanced services and reimbursements for premises. And you can see that the spend has actually increased from about 45 million to 48 million in those 2 years. And then the bottom half of the table is sort of things outside of that, like improving access, any transformation schemes, the PCN network DES elements, and then bits of PMS premium and COVID funding. So if you would take it all together, the spend has increased from about 51.4 million to 51.4 to 57.7 million. So it's definitely, spending is increased in years. We've not lost any along the way, despite all the changes. So I haven't really got a lot else to say about it. It's quite, I'm hoping it's self-explanatory. But
Yep, I'm getting lots of nods. Have we got any questions or comments for Caroline, please?
I think it just demonstrates a really good balance between funding core clinical services and then also being able to invest in infrastructure, which is improving things like access to services as well. So it's not just a narrow focus, which is very commendable.
Thank you, Phil. Gary, you put a comment in the comment box. I wondered if you wanted to raise that. I think it's important.
Yeah, I can do. It was just following on from what Sean was saying about the how we don't see or able to record the consultations that take place within clinic, because then they don't sit within the GP appointment ledger within System 1 or EMIS. It's a chunky piece of work and it's quite technically complicated. I say that, it's certainly over my head, but there are some real data gurus that sit within some of the practices, and I think that that George has been able to put together a joint CCG practice group to address this, look at ED attendance and the link to deprivation, and actually start to pull together a lot of the population health data by sharing what we know and what practices know. There's a real development of trust there that I think is absolutely stunning. But coming back to Sean's particular point, we know there is a huge cliff edge of appointments that just never get recorded, and it doesn't do general practice any favours for them not to be seen and out in the open. So because you never get a true picture of the level of service that's being delivered. So I hope we get that as something we can report within kind of probably within our WAF report at the end of Q4 as well, because that work's a direct result of the Winter Access Fund and the questions raised there.
Thank you, Gary. Any comments to Gary's response? No. Okay, thank you. It's over to you, David, please. Your Nhs Ei Report, please.
Thanks, right. So no items for decision this meeting, just a few things for noting. So the first couple of points are just links to contracts and guidance updates relating to the medical contracts and the network DES. I did put a link specifically to some guidance around the new digital requirements of the contract. The main change being that practices must now offer and promote online consultations and video consultations to their patients. Well, to be fair, the majority of practices in the Vale of York are already doing this, so that won't be a significant change. But the main item I was just going to cover off is 1.5. It's the general practice access routes campaign resource. So just a bit of background to this. Earlier, well, going back to last year, the NHS England digital primary care team approached us in Humber Coast and Vale to see if we'd support them developing a communications toolkit to increase online consultation usage. And after sort of scoping what we thought was the right way forward, we felt just arbitrarily increasing online consultations or encouraging patients to do an online consultation wasn't the right thing, but we should just do a broader campaign around educating patients on access. So what then that led to was it was focused in Hull as our sort of most deprived area within Humber Coast and Vale, but we want it to be a Humber Coast and Vale wide campaign. So Priory Medical volunteered through Vale of York as our sort of representative PCM, and a communications company worked with 10 PCNs, with practices, practice staff and patients to understand access, how they understood access, how they needed educating around access. And in the end, a communications toolkit was developed, which is being well received by the national team. They pushed that out nationally prior to actually being evaluated, and it just tries to emphasise to patients that you can access general practice either through the telephone, through online consultation forms, or sorry, phone's going off there, or taking into account inclusivity around access, that hard to reach groups can obviously attend in person as well. And there's a toolkit there that practices can use directly. So it's not something that CCGs are promoting to patients. It's very much empowering practices to communicate with their patients as they best see fit, through social media, through posters and bulletins and things like that. I just wanted to specifically mention that because, as I said, Priory had put a lot of work in supporting it, and it's been a good piece of work recognised nationally. Just wanted to acknowledge their contribution to it. And I think that's everything from me. Thanks.
Thank you, David. Questions or comments? No, you've got away really lightly with that. Well done, everyone. And that brings us, unless anybody's got any other business. No. Okay, that brings us to the end of this afternoon's part 1 session. Some of us are joining for a part 2 session, so I'll welcome you all then. Phil, did you have any questions or comments? Or no, you're just smiling at us. That's fine. We like a good smile. I'll sort out some key messages to governing body. There's a lot to think about there, and some fabulous work being done across the patch. And I think the thing strongly for me is that we're all in this together, and I think we're working really strongly together, and that's really good to see. So thank you, everybody. As always, thank you for all of your comments. I think we always need to be challenged and challenge ourselves. I look forward to seeing you all on the 24th of March for our next Primary Care Commissioning Committee at 1:30. Until then, take care. Get in touch if there's anything that you need us to discuss, and hopefully that some of the presentations that we've seen today we can share with you too.